Hello and welcome to the Hellp Syndrome presentation for Lifespan 3. Hellp is an acronym that stands for hemolysis, elevated liver enzymes, and a low platelet count. Hemolysis is the rupture or destruction of red blood cells. Elevated liver enzymes would be your elevated AST level or ALT level. And a low platelet count would be any count below 150,000 platelets. This is a life or death situation and should be taken very seriously. Preeclampsia may be the first sign of Hellp syndrome, and this can often lead to a misdiagnosis. Some preeclampsia symptoms include proteinuria, which is protein in the urine, high blood pressure, which is 140/90 or greater, edema, most commonly in the upper and lower extremities, and an excessive weight gain. A little history about Hellp syndrome. In the early 20th century, Hellp syndrome was known as edema, proteinuria, hypertension, gystosis type B. It was once known as a severe form of preeclampsia, and some believed it to be an entity on its own. It was renamed in 1982 by Louis Weinstein. The cause of Hellp syndrome is still to this day unknown. Although the cause of Hellp syndrome is unknown, there are many risk factors involved. Maternal age older than 34 years, multiparity, white race or European descent, and a history of poor pregnancy outcome are all risk factors for developing Hellp syndrome. Hellp syndrome occurs in 0.1 to 0.6% of all pregnancies and in 4 to 12% of patients with preeclampsia. It usually occurs between week 27 of gestation and delivery, immediately postpartum in 15 to 30% of cases. The prognosis for Hellp syndrome depends on the classification of the disease. For most cases, however, there can be a stabilization within 24 to 48 hours postpartum. Women who have been diagnosed with Hellp syndrome are at an increased risk of preeclampsia or pregnancy-induced hypertension, in addition to preterm delivery, fetal growth restriction, and placental abruption in future pregnancies. Women who have been diagnosed with Hellp syndrome are also at an increased risk of cardiovascular disease. Categories of severity for Hellp syndrome include the Mississippi classification. This is measured according to the blood platelet count of the mother and divided into 3 categories. Classification 1 is severe thrombocytopenia with platelets under 50,000. Classification 2 is moderate thrombocytopenia with platelets between 50,000 and 100,000. And finally, classification 3 is a more mild thrombocytopenia with platelets between 100,000 and 150,000. You hear preeclampsia a lot when you are talking about Hellp syndrome, and that is because preeclampsia is associated with Hellp syndrome. The placenta is limited to oxygen supply and nutrients through poor blood vessels. A mother's blood pressure rises. This is the body's fight or flight response to try to compensate pushing blood through constricted blood vessels. High blood pressure over a long period of time is critical to multiple organs. Platelets activated to coagulate the hemolytic cells turn into DIC. And DIC is disseminated intravascular coagulation. This is a widespread activation of the clotting cascade that results in the formation of blood clots in small blood vessels throughout the body. Some clinical manifestations of Hellp syndrome are blurry vision from increased blood pressure for long lengths of time, severe headaches not relieved with pain medication, nausea and vomiting that continues to worsen over time, abdominal pain or tenderness, and fatigue or malaise. The treatment of Hellp syndrome is supportive therapy. Treatment includes blood pressure management using labetalol, which is a safe blood pressure medication to take during pregnancy, seizure prevention with magnesium sulfate, which is a neurosuppressant, and possible blood transfusions if needed in patients with DIC. In some cases, delivery of the baby is the safest treatment for Hellp syndrome. A synthetic Pitocin would be used to initiate labor, and if doctors believed there was a low survival rate for the baby due to inadequate lung function in preterm birth, the mom may be put on bed rest in hopes that symptoms will subside. Depending on results from lab work and the mother's current condition, an emergency cesarean section may be called for. There are many things that can be done to help prevent preeclampsia and Hellp syndrome. Being physically fit and staying in shape, regular prenatal visits, notifying your physician of any previous high-risk pregnancies or family history of Hellp syndrome, preeclampsia, or other hypertensive disorders. Understanding warning signs and report them to your physician immediately, and trust yourself when something doesn't feel right. The nursing diagnosis for Hellp syndrome would be excess fluid volume related to compromised regulatory mechanisms as manifested by blood pressure changes, decreased hematocrit, decreased hemoglobin, edema, specific gravity changes, and/or weight gain. Fluid volume excess signs and symptoms may include edema in dependent areas first, face and whole body later, and your skin would be taut or shiny. Abounding pulse and elevated blood pressure, jugular vein distension, shortness of breath with either crackles or cough, excessive weight gain, altered level of consciousness with confusion or lethargy, muscle cramps or weakness, and nausea and vomiting. Monitor daily weights for sudden increases. Use the same scale and type of clothing at the same time of day, preferably before breakfast. Body weight changes reflect changes in body fluid volume. You're going to want to monitor your vital signs, including blood pressure and pulse. Know that heart failure results in dyspnea and edema. A secondary characteristic to heart failure is weight gain. The obstetrician is going to monitor for development of conditions that increase the client's risk for excess fluid volume. These include heart failure, renal failure, and liver failure, all of which result in decreased glomerular filtration rate and fluid retention. Hellp syndrome's effect on a baby varies from pregnancy to pregnancy. For instance, if a baby weighs at least 2 pounds at birth, he or she has the same survival rate and health outcome of a non-Hellp baby. Under 2 pounds at delivery causes a lower survival rate. Hellp babies will need longer hospital stays and will have a much higher chance of needing ventilator care. Patients with Hellp syndrome should be educated on the risk of maternal and fetal morbidity and mortality in future pregnancies. Next, we have a couple NCLEX style questions for you. Question number 1, which of the following characteristics cause a woman to be more prone to develop Hellp syndrome? Select all that apply. Caucasian, prima gravida, family history, multigravida, or Native American. And the answers to this question is Caucasian, family history, and multigravida. Prima gravida and Native American are not characteristics that cause a woman to be more prone to develop Hellp syndrome. Question number 2. When administering magnesium sulfate to a client with preeclampsia, the nurse understands that this drug is given to do which of the following? Decrease pulmonary edema, prevent seizures, decrease cardiac output, or increase pulse rate? The answer to this is to prevent seizures. Magnesium sulfate is a neurodepressant which helps prevent the occurrence of seizures or seizures from beginning. Question number 3. When evaluating a client's knowledge of symptoms to report during her pregnancy, which statement would indicate to the nurse that the client understands the information given to her? Call the clinic if my ankles swell after a long car ride. If I have a headache and it is relieved with Tylenol, I should go to the emergency department. If I have blurred or double vision, I should call the clinic immediately. I will call my doctor if I have unusual cravings. The answer to this question is if I have blurred or double vision, I should call the clinic immediately. The other options are all normal occurrences in pregnancy. Okay, and that wraps it up for the presentation on HELP syndrome for Lifespan 3. I hope you enjoyed it.